Good morning, dear colleagues. My name is Radost Asenova. I'm a Bulgarian family doctor, and I have the privilege of serving as the co-chair of the scientific committee for the 25th WONCA World Conference here in the beautiful city of Lisbon, and as a member of the executive board of WONCA Europe. It is a great honor to me to stand before you and open the session today. And I'm so happy to see so many colleagues from across the world gathered here, united by our commitment to family medicine, and that makes our community so special. Today we welcome a keynote speaker who truly needs little introduction in the world of family medicine, Professor Richard Roberts. Professor Roberts is a professor emeritus and past chair of the Department of Family Medicine and Community Health at the University of Wisconsin, USA. He is both a family physician and attorney who has devoted more than 35 years to practicing full scope of family medicine, caring for people of all ages, performing procedures including endoscopy, surgery, and providing care across settings from the home to nursing homes, hospitals, boarding units, and intensive care units. Beyond his clinical career, Professor Roberts has been a leading figure in quality improvement, primary care redesign, patient safety, and human factor science. He has contributed to over 36 national and international guideline panels, is a certified professional in patient safety, and is a past president of both WONCA World and the American Academy of Family Physicians. We are privileged to have Professor Roberts with us today, so please join me in warmly welcoming Richard. The floor is yours.
Thank you. Many thanks to the scientific and host organizing committees and the Portuguese Association. It's wonderful to be back in Lisbon. I have no conflicts to report. I don't know if it's showing for you because it's not showing there, all right? We're not getting slide advance on the screen. I can tell you what the screen says. It says I have no conflicts to report. I don't know if we have one of the AV folks here, but there we go. Thank you. Now we're going. So the last time I was here was in 2014, and I was asked to speak at that time on the challenges in measuring and improving quality in primary care. And I shared what I knew about the science and some of the experiences I had, but I think the most important thing that I shared was in all my travels over the preceding 20-some years, I'd had the chance to observe more than 400 family doctors in about 4,000 patient encounters in 70 countries. And so part of what I'm going to do this morning is give you the additional 11 years since then, which now has me up to about 5,000 doctor-patient encounters with about 500 family doctors in 100 countries. We always talk at the start of talks like this with the quadruple aim, which most of us are familiar with. The goal there is to improve the patient experience and population health while lowering costs, and the fourth aim being added relatively more recently, taking good care of the healthcare team. What I would like to do with regard to human factors science is to try to address the what it is, why it is, and what's going to happen next. Because human factors science, to me, reflects the logical evolution of years of efforts to improve the quality of care. I would define human factors science as a multidisciplinary effort to understand interactions among people, their tasks, and their setting that takes account of human capabilities and limitations, strives to create systems for optimal performance and human well-being, and aims to achieve more effective, efficient, and safe health care. So why do we have human factors? Well, there's a history to this, and it goes way back, and I need to share that with you because I think it helps us understand better why we've arrived at human factors. It begins with malpractice, which, as a way to address the problem malpractice, led us to risk management. And if you look at the history of malpractice and risk management, it's about 4,000 years old. Code of Hammurabi was the first place that we could find evidence that there were formal rules laid out, such that, for example, if a surgeon were to injure a patient, there was the eye for an eye sort of standard, so the surgeon would lose a hand or an eye. Now, that might seem pretty rough, but the alternative in those days was the family would come and kill the surgeon, so it was actually a step up from what they'd had. And as time went by, people began to recognize that outcomes had to be more than just physical outcomes that you took account of. It included things like ethical and moral considerations, preserving, for example, confidentiality. And folks like Hippocrates and Maimonides helped in that regard. A very important development in this journey of quality was Florence Nightingale, who made great use of graphics to show data collected on the hospital battlefield during the Crimean War that she could then share with the leaders in terms of deciding what to do and how to best treat injuries and all of that. And then most recently in the moral ethical arena is the World Medical Association Declaration of Geneva that, in fact, most medical students now around the world will take as their oath. It's been amended several times, and I think the latest iteration is about 2010. But as time went by, using that name, blame, shame game approach of malpractice really wasn't improving things. It didn't help to cut off a surgeon's hand. There was still, bad surgery happening. And so with the explosion of biomedical information beginning after World War II and the rise of specialism, you saw a greater push toward developing guidelines, often through professional associations. In fact, the United States, the first group was the American Academy of Pediatrics in the early 1930s. And what they did, and this is what I had the chance to do for 30-some years, was sit a group of experts around a table, hash through the literature and their own experience, and come up with practice recommendations. But here was the problem. The problem was when you looked at the evidence, it wasn't so good. So John Ioannidis, a real expert in evidence, did one study that looked at what he felt were the most influential articles in the world's medical literature. These were studies that had been cited more than 100 times. He found 49 of them, and in 45 of those studies, they claimed that their intervention that they were testing was effective. But if you look even further ahead, only 20 of the studies had their findings replicated. And of course, that's an important principle of the scientific method, which is reproducibility. So effectively what that meant was that less than half of the time, 44% of the time, could you say that the recommendation of this prestigious guideline or piece of evidence was correct. And the scary thing is you didn't know which half. Now, why is the studies that we have available to us, why are they as bad as they are? There's a lot of reasons. Many times the design is not appropriate to the question being asked. The sample size may be too small or not representative. The analysis that's undertaken on the data can be incorrect. There's unquestionably more bias and even fraud. If you track retractions that are happening now, they're more than ever every single year. It's several hundred a year now in some of the best journals in the world. And so what I would say if you go to the evidence is even when you're talking about the study populations, the conclusions of the study are kind of shaky. And if you look at that evidence for your patient standing in front of you, it sucks. At least that's a technical term we use. And the other part of the problem with evidence is that it's growing faster than any of us can or will be able to manage. When I graduated from medical school in 1980 and took my board certification examination, I knew I was going to have to retake the exam every 7 years. And the reason was that the doubling time of medical knowledge at that time was every 7 years. And it was projected to be around 3.5 years at 2010. Anybody guess what it is right now in 2025? It's 6 weeks. So that means that half of what you know right now will be out of date, incorrect, or incomplete within 6 weeks. And the truth is, and the older doctors in the room know this, you never learn medicine, you're always relearning it. Because people were really not responding to the guidelines, because the evidence sucked, and it didn't seem relevant to my patient, and there were all kinds of other barriers in the way, what finally started to get people's attention in this whole area was safety. And there were 2 seminal books that came out of the National Academies of Medicine in the United States. The first, To Err is Human, in 2000, and then the second, Crossing the Quality Chasm, in 2001. And very articulate proponents like Don Berwick would come out with statements like, we kill the equivalent of a Boeing 747 every single day in the United States because of medical error. And that's a pretty impressive number. The problem was that nobody really had a way of fixing that. But that idea that safety is a problem and the doctrine of first do no harm is being violated every day has captured now worldwide attention. The World Health Organization has a global patient safety action plan through the end of this decade. And the second objective is to try to get countries around the world to build high reliability systems and health organizations that protect patients daily from harm. And in that section, it also speaks to the fact that human factors or ergonomics is the key to creating these high reliability systems. So you see such things as the WHO safety checklist, which has indeed seemed to improve surgical bad outcomes by a considerable amount. The other thing that's helpful to remember as we think about delivering quality care is that there are very important kind of aspects to the whole quality picture. So you think of structural things and have structural measures like, is a facility safe? They have electric power, the room's clean, and so on and so forth. And then you have the process of care. Is the way that we do the surgery, the process of doing it, good or not? And then lastly, and most importantly, the outcomes that patients experience, physical, psychological, and otherwise. And we try to measure all of these in getting a better picture of quality. Parallel to the efforts being made in the medical community, however, were, in my view, much more effective strategies being used in industry. And with industrialization in the 1800s around the world, people that ran big factories were concerned that their workers were getting injured, partly because they weren't as productive when they were injured. And in fact, a Polish scientist in 1857 coined the term ergonomics, the science of work. What was fascinating to me looking back, though, and in many ways they were much smarter than we doctors were, was that they recognized early on that their initial efforts to train the workers better to avoid the harms that were happening just wasn't effective. And yet our system is still built on the premise that we either name, blame, shame the individual, or we throw some guidelines at them, or we scare them with safety statistics and then expect them to do better. But what ultimately drives the outcomes is way more important, is the system that they're working in. And so the shift in the industrial world was from individual workers to designing safe systems. Highways are a good example of that, whether it's the Autobahn or whatever. They've been able to engineer safety into the highway to save us from ourselves, being the not always good drivers that we are. Now, to do this requires a lot of different kinds of expertise in engineering, psychology, different subtypes of psychology, physiology, and so on and so forth. And that is what makes human factors a bit of a challenge, because that's a lot of different people and talents to bring together, but also, in my view, a lot of fun. The real giant in the last half of the 20th century when it comes to human factors is a Japanese industrial engineer, Shigeo Shingo, who worked for Toyota and helped them develop the Toyota production model. Now, Toyota, as you may or not know, was, when they first started, kind of the laughingstock of the auto manufacturing world, because when their cars would be delivered, the fenders would fall off and the car wouldn't start and whatever. And so they brought in experts, people like Edward Deming, a statistician from the United States, Professor Shingo, folks like that, and they completely redesigned the model used to put cars together. So from the 1920s on, what all car manufacturers did is they had an assembly line model, which Henry Ford really developed. And you'd have one group of people putting together the frame, the next group putting the body panels on, and the third putting the engine in, and so on and so forth. But the problem with that approach is by the time the car came out, half of them had to go back and start over again because of defects that were found. What the Toyota production model did is it had a single assembly team that did it all. Does that remind you of primary care? And what they did was looked at the workers as actually researchers, scientists, helping them design better processes and ultimately better products. And that was the genius of Toyota and Professor Shingo. Now, what's also interesting, however, is that there's been no other auto manufacturer that's exactly able to repeat what Toyota's done. And my sense of it, and I'm not an expert in the auto world, but my sense of it, having visited a few Toyota plants and a few General Motors plants, is that the other automakers just don't quite get the philosophy that you turn your workers into researchers who are highly invested in continually improving the process and the product. And so there are many things that we give Dr. Shingo credit for. He was one of the co-authors of the lean design approach, ideas like Kaizen, which is continuous improvement, and so on. His guiding principles, I won't read all of them to you, but his notion always was you make it simpler, easier, safer, less costly, and begins with basics, just things you learned in kindergarten. You lead with humility, you respect every individual, and then you build up from that. Other areas also began to embrace the concept of looking at errors and the potential for errors in a more holistic way. So the military, for example, you had to have a way, if you were standing sentry, to pass along the information from your watch to the person that succeeded you. So it was a technique called SBAR, Situation Background Assessment Recommendations. It was a very succinct, they had to do it in less than 2 minutes. Here's what's been happening. Here's the background about why I'm concerned about this or that. Here's my assessment or conclusion, and here's what I recommend you do about it during your watch. 2 minutes or less, and has a lot of relevance in places like emergency rooms and operating rooms. In aviation, a key concept was crew resource management. You know, the pilot was the captain of the ship. Well, the problem was that sometimes the pilot didn't know something bad was happening. So what CRM does is it empowers every person involved with the flight to be able to stop that flight, just like the red button at Toyota plants where they can stop the assembly line. But whether it's the gate agent or the baggage handler, once they announce we have a problem, the flight doesn't go until the problem's addressed. And that's saved a lot of lives. In other kinds of manufacturing, they aim for things like Six Sigma. So, if you look at standard deviations, the first is, 67% and out. Well, Six Sigma is 99.998% error-free, or only 3.4 defects or errors per million opportunities. We talked a little bit about Dr. Shingo and the lean design concept, continuous and total quality improvement. These are all some of the strategies used. Healthcare came around to these approaches really beginning in about the late 70s and 80s. It really started in many ways in anesthesia. And again, the problem in the United States was malpractice, where the anesthesiologists were getting sued all the time for catastrophic brain injuries during general anesthesia. And they found that just using 3 fairly easy to use, fairly affordable technologies, pulse oximetry, esophageal stethoscopy, and exhaled capnography, reduced brain injuries to essentially zero. So they were going with something like 20 to 50 cases per year in the United States to zero. And their malpractice situation improved a lot. The surgeons found checklists very helpful because, indeed, doing a surgery is a bit like launching a rocket. And there's certain steps you go through, and you want to make sure each step's been addressed. And obstetrics has had a similar approach, especially around teams. So, for example, the advanced life support program in obstetrics also was developed by family doctors back in the early 90s, and it brings a team together to actually work through common maternity care emergencies. And it's not just the more medical stuff, it's also how do you talk to a family where they've had a stillbirth. So it's a sort of typical family medicine holistic approach. And as we realize how much impact our communities have on our patients' individual health, we also need other tools to reach out into the communities, like community-oriented primary care, which is a way of engaging communities, first developed by Sydney and Emily Kark in South Africa. Also beginning to incorporate, especially now with electronic health records, the social determinants of health to help guide what kind of actions we should have. So these all sound perhaps like nice to have, but do they really do anything? Well, the first example I'll share with you was done by Peter Provenos and colleagues at Hopkins, where they had over 100 hospitals in Michigan, and they wanted to address the problem of bloodstream infections that were due to indwelling, like central venous catheters for medicines and monitoring. And at the time they started the study, whether it was in a teaching hospital, non-teaching hospital, big hospital, small hospital, they were all averaging about 2.5 bloodstream infections per 1,000 catheter days. And so they went through a series of steps to identify all of what was going on, develop a very precise protocol about how to insert and manage a catheter, recognize early the problems that might arise, and intervene. Well, within approximately a year, virtually every hospital was at 0. So, if you go from this amount, that amount, that's pretty good. If you go to 0, something's going on there that's working. Now, that may all sound well and good when you're talking about hospitals in wealthy countries with lots of resources, but this is taken from a recent webinar that our Human Factors group at WONCA we've been doing these webinars for a while, and this one was given by Dr. John Toussaint, who went to South Africa to do teaching on lean design, some of Professor Shingo's ideas. And this was in a pretty rough area. It had high neonatal mortality rates. They were averaging something like 20 to 30 babies dying every month. This is Laratong Hospital. And so John came in and taught lean design to the staff. And the woman there in the upper left corner was the clinical unit supervisor, and she led the group through, okay, what are we going to do to address neonatal mortality? The key thing here, and this is the important lesson that comes up again and again with human factors, is even though she was the clinical unit leader, she was not the one that actually fixed the problem. It was the people directly delivering the care. Her job was to help lead them, encourage them, to come to those answers and then to implement them. And within about 6 months, their neonatal mortality rate dropped by 80%. And this is in a very busy, overwhelmed hospital in a very deprived area. So these techniques, these models seem to work almost no matter where you are. And you've heard of some of them already and probably used them, the Plan, Do, Study, Act, where you come up with the assessment of what's going on, you develop a proposed solution, you pilot it, then you study or assess the impact of the pilot, and then if it's working, you tweak it a little bit, make it better yet, and then begin to do it more widely. Some people, instead of PDSA, like PDCA or Plan, Do, Check, Act, but it's the same thing. That was actually developed by Edward Deming in his work with Toyota. If you're actually trying to identify the causation for your problem, that can be kind of tricky because most things are multi-causal. And so a fishbone diagram is a fairly straightforward way of doing this, identifying in great detail. One of the things I love when I visited Japan and met with some of the manufacturing folks is that they have what they call the 5 whys approach, WHY. So, okay, we have this problem. Well, why do we have that problem? Well, it's because of this problem. Well, why do we have that problem? And by the time you've gone through it 5 times, you've usually got to the nub of what the problem really is. You can also use Gantt charts to track your progress, give people assignments, and make sure everyone's staying on time. And much of this depends on having teams. Now, sports coaches like to say to us, there is no I in team. And my answer back to that is, yeah, but there is no we in team either. But if you hold a mirror up to team and look at it honestly, you will realize that there's a me in team, because the latter is. Well, why is that important? Is that team, like any kind of intervention, is not an unfettered good necessarily. So let me ask the group, how many people here work in teams? Most hands. How many are happy with their teams? Quite a few, but not quite as many. How many are just deliriously happy with their team? Think it's the best thing since sliced bread? Not too many hands at all right? So teams can be greatly advantageous to us. They help improve access to patients because there's usually somebody around, and there's evidence that they may improve outcomes and the care experience. We get more diverse points of view, which usually makes for better solutions. There is evidence that it will reduce burnout. We're able to do task delegation, which allow the other members of the team to work up to the level of their credentials. And in some ways, what I call it diffusing accountability. It's hard to sue a team. You actually end up having to sue a person. But if you're standing behind a team, they did it. And I've actually seen this in lawsuits. And it doesn't sound like a nice thing to say, but we're human. And who wants to be the person that's named in the suit? But there is some toxicity to teams. You actually reduce personal continuity. I'll show you a study in a second. You become more disease-focused. You decrease confidentiality as you spread the patient's information around. You may have more potential conflicts because you have more and different people around the table. You have the increased oversight burden that typically falls on the physician's shoulders. You actually have task degradation. And what I mean by that, and I'll give you an example from England, when I was serving on the Greater Manchester Patient Safety Translation Research Center, I would go around and visit British GPs, and this was as the quality outcomes framework had been rolling out for a few years. And that program compensated GPs fairly handsomely for hitting certain targets, hemoglobin A1C levels, blood pressure, and so on. And I remember vividly interviewing one older GP, and I said, what's the QOF been like for you? He said, it's probably helped us in some ways better organize our practice, and I'm making more money. He said, I had to hire a nurse to manage my diabetes patients, and I had to hire another nurse to manage my asthma patients. And 5 years later, I don't know how to manage diabetes or asthma anymore. And my patients are upset that they never get to talk to me. And that's a problem. We can create the same fragmentation that plagues many of our developed health systems right within our own primary care practice by adding more people. What's the right size team? 1, 3, 5, 15, 40? I have one of my patients who happened to be an industrial engineer, and he was retired. He was a good friend. We used to talk. Half our visits were talking, human factor stuff. He had had a bad burn on his arm, and he had to come in for daily dressings for 6 weeks. Now, we have a total of 52 employees at our clinic. If you add up our residents, the faculty, nurses, reception, x-ray, blah, blah, blah. He kept track. He saw 40 of the 52 in 6 weeks' time. And because we have an electronic record that patients have access to, he could see what everybody had noted. And he would point out to me the absolute contradiction one to the other. He would point out that the quality of the photos that each person took when he was in each visit to track the wound was often very bad. And so unless you were the same set of eyes, you really didn't know how it compared to the visit before. So you have this task degradation problem, the too many cooks spoiling the broth problem, and ultimately from a liability standpoint, it typically falls to the physician because you're seen as the leader of the team. These are some very recent studies, and I apologize for being so busy, but basically what this study is looking at is when you have a very formal team structure, and in the United States, people often will pursue this to get what's called patient-centered medical home certification. What happened when they compared those sorts of practices to practices that were usual care, the number of visits with your primary doctor actually went down, not surprising. And overall, for both kinds of clinics, it was not good. So, for example, in the first year, you had a 75% chance of seeing your doctor in a PCMH and then 80% in a non-PCMH. But that dropped over 5 years, so that within 5 years you had less than a 50% chance of being seen by the same person. One nice book, kind of a primer, if you're interested, and it's free, it's available as a PDF online, is from Ireland, and it's an introduction to human factors for healthcare workers. It was mentioned in one of the earlier talks this morning that what we do in primary care is quite different than what the rest of the health system does. And an engineer taught me this. He was somebody that actually studied primary care and spent time watching doctors and patients. And he said, you know, the assembly line approach that we use for things like surgery, we call it a linear model, step A, B, C. That works fine there because that's not for primary care. Primary care is a complex adaptive system that aims to develop a customized solution for each unique patient. And so we really need to think in systems. We really need to think about complexity. These are the things that drive what happens in our domain. These are the folks currently working for about the last 3 years with the core, we call it the Core Group for Human Factors, and we've put together a series of webinars. Those are free online through the WONCA YouTube channel, and we also are working hard at trying to develop a human factors project that we hope will go around the world in short order. But again, we've got to get that up and funded first. There'll be a workshop shortly after this in, I guess, room 4 here, if you're interested. And I was going to finish, and I would ask you to indulge me a brief story that taught me a bit about human factors and about humans. So Rob, when he came to me, was a 64-year-old man who basically presented for opioid refills. He had come newly to the community to be closer to his daughter, his only living relative, and her young child. The rest of his family was either dead or divorced from him. And when he sat me down and showed me how much he was taking, I almost fainted. I mean, it was literally in the order of thousands of milligrams of short and long-acting opioids. And I said, excuse me a second. I said, I got to get a drink of water. I got a drink of water. But I made a phone call to his previous physician that had been prescribing for him, who I knew. I'd trained the guy, and he was a good doc. And I said, what the hell were you doing? And he said, well, nothing else has worked, and, you know, Rob's having terrible, terrible pain. Well, the story was that he had been a star athlete in high school, went into the military, served in Vietnam, saw action there, apparently encountered horrible things there. Then he becomes a police officer, actually a motorcycle cop. And when he's in his early 40s, he comes upon a terrible car crash. The car's about to explode and set on fire. He pulls the husband and wife out of the front seat, and unbeknownst to him, there's a little girl on the floor in the back who dies. And I think he carried that burden for a long time. He also had thoracic and lumbar vertebral fractures, which also was a source of his pain. And he had this terrible pain from the waist down, bilateral, a little unusual, with bilateral terrible neuropathy. And he was on thousands of milligrams. He'd been through 6 or 7 pain clinics, about every test you could imagine, and my job now was to fix his pain and give me my damn refills, will you, Doc? So what I did right at the beginning is I said, look, first of all, you don't have to persuade me you hurt. I believe you. All of what you're hurting. So let's not fight over that. You don't have to tell me that you're 20 on a 1 to 10 pain scale. You're hurting. But I said, what I'm going to ask you to trust me on is that job 1 is to do the best we can to make the pain as good as we can. But job 2 is to try to get you down or ideally off these opioids, because they're going to kill you at some point. You know, he had been a heavy smoker, he'd had bypass surgery, he'd stopped his cigarettes, but I said it's going to kill you at some point, especially if you get older and develop sleep apnea and the like. So he agreed to that. I wrote the refill. It took 5 years. Started with some buprenorphine, tried a whole series of other modalities that had come newly online. But with the weaning to buprenorphine and then eventually off, and a spinal stimulator, he was essentially pain-free at 5 years. And man, was he happy with that. Now, the story, unfortunately, does not have a happy ending. Because we were going to remove the stimulator, it was actually time to change the electrodes. We were going to remove the stimulator, and when he had his preoperative chest x-ray for that, there was a big pancreas tumor. And there was not a lot they could do. He had radiation for a short while. It did reduce the size. It helped a bit with his symptoms. So I started making home visits, worked a deal out with the hospice nurse. We'd alternate visits, and watched him begin to sort of wither away as time went by. One thing that surprised me, though, was he could be a pretty nasty guy, and he would chew out the staff, and one of the rules was you can't chew out the staff. Come to me. So I got chewed out, and that was fine. I got used to it. In fact, when he would get really frustrated with me, instead of calling me Rich or Dr. Arbors, he called me Dr. Dick. Dr. Dick, Dr. Dick, Dr. Dick. And I said, come on, man, come on, Rob, you know what it is. But we worked through that. But what had happened with the improvement in the pain was he actually had gotten connected to his daughter again. She didn't want to go around him because he was a nasty guy. He began to get to know his granddaughter. So that was all good. My very last visit with him, he was pretty weak. I knew we were getting close to the end. And because he was having some recurrent laryngeal nerve involvement, he would kind of lose his voice at times when he spoke. So as I was getting up to leave, he kind of motioned me over to him. And as I leaned in to try to hear him, he actually pulled me up close and he gives me a kiss on the cheek. And I must have had a surprised look on his face because I wasn't really expecting that. And he said, was that okay? And I said, well, it's not every Tuesday I get kissed by a cop, but hey, you know. And then he says to me, he says, well, I just want to thank you. He said, you gave me faith and you gave me hope. And what I want to tell each of you that you do is you give faith and you give hope. No matter how bad the situation, remind yourselves of that on the days you're thinking, why am I doing this job? And human factors will allow you to do it better, more efficiently, more humanely. Because if you're waiting for the governments and the funds and the health plans and the clinical managers to fix it for you, forget it. That cargo ship is not coming. So instead of doing it top down, let's do it bottom up. Because I've been in your practices. I know you can do this. But you need some tools and you need some knowledge. And that's what human factors will give. Obrigado.
The clock kept jumping.
On behalf of all of us, I sincerely thank Professor Roberts for sharing with us your wisdom and experience. So thank you once again. And dear colleagues, now I would like to invite you in our virtual corner to join Professor Roberts, and also to remind you that Professor Roberts will be leading a workshop in 30 minutes, so I fully recommend you to join the workshop as well. Thank you.